right, good morning. My name is Ryan Spiker. Appreciate the opportunity to speak today. We're going to talk about some complex scenarios, really looking at multiple fractures within the cervical spine. These are my disclosures, none of which are pertinent today. So, an outline, we're going to talk about some basic principles. We'll talk about non-contiguous cervical fractures, so upper and lower. We'll briefly touch on contiguous fractures in the cervical spine, and then some take-home points. So you're on call next week. This comes in. You have this C1 burst, associated C2 fracture, also has the C7 vertebral body fracture with the facet injury. There's a lot going on here. So how do you think about it? And so with these complex injuries with multiple fractures, I think it's important to go back to the basics. So remember to look in other areas of the spine, not just the cervical spine, because they may have even other fractures beyond the two that you've already identified. And then go back to some of those basics of making sure you look for the verts, make sure you look for your screw paths. When there's a lot going on, I think sometimes people jump quickly to conclusions about what they're going to do. You want to make sure you're taking care of the patient, not just the fracture. So these are high energy injuries, and it require you to be a physician and not just a surgeon. And then remember those goals of care, those basics: decompress, align, stabilize. In the upper cervical spine, I think in general that posterior fixation can be biomechanically superior in a lot of situations. In the subaxial spine, I think when you can go anterior, there are benefits as to the ease, and you can keep those in mind, but each fracture is certainly going to take a very nuanced approach. When we look at non-contiguous fractures within the cervical spine, we can see that they're rare beasts. So these are not things that we're seeing on a weekly basis. Some studies suggest it's around 2 or 3% of cervical fractures will have a second cervical fracture. They're high energy injuries, so about 3/4 of these patients will end up having either cranial or thoracic injuries. And in the small series that have been reported, their outcomes appear to be relatively similar to other types of cervical trauma patients. It's important to separate intracervical non-contiguous injuries from spinal non-contiguous injuries. There's a lot of literature on spinal non-contiguous injuries. We're at the cervical spine meeting, but I think they'll allow me to speak briefly about thoracolumbar trauma and just say those injuries are certainly much more common. So CT studies suggest about 10%, MRI studies suggest 20% of non-contiguous injuries if we're looking at the entire spinal column. When you're looking at non-contiguous cervical fractures, I think it's important to think about the primary versus the secondary injury. The primary injury is really where there's the most neurologic compression, it's the most unstable, it's the injury that's really getting your attention and you're most concerned about. The secondary injury is obviously less so. There are two similar injuries, they both have similar amounts of instability and compression, then in general the one that's more cranial or more proximal is going to be the one that you're going to address first. But by identifying that primary injury, you can start to come up with a plan, and you don't want to sacrifice that plan. That's something that you're going to want to really focus on. With non-contiguous fractures, you have to consider, am I changing my approach because there's two fractures? And I would say, again, you're going to focus on the primary injury first, and then you can treat each injury the way you want to treat it. I think if it's a very kind of 50-50 type of fracture, it's a subaxial burst fracture that you could go in the front and do a corpectomy, you could go in the back. If you're already in the back for another injury, maybe it pushes you and makes the tie go to the runner. But I think it's okay to treat each fracture the way that you prefer and feel comfortable treating it. So in a case like this, you have upper cervical instability, you have a lower cervical fracture. I think it's reasonable to go and fix the C1-2 first, then come down, and since you're already posterior, you can get fixation posteriorly of that fracture, which otherwise at C7 may be an anterior corpectomy. Contiguous fractures, there's really not a lot of data about these. So we know that if you have associated facet fractures next to burst fractures, those certainly confer some instability. But the instability is not always greater than the sum of its parts. So if you have non-operative, basically stable fractures, and you have a lot of those, that doesn't suddenly become operative. And there are multiple case reports about spinous process fractures, TP fractures. These non-operative fractures, even if there's 10 in a row, they still remain non-operative. And so you really just want to treat the areas of instability. You don't have to treat the adjacent level just because there's a fracture if it's not a fracture that's conveying instability. So I'll go through one other case. So this is a 27-year-old female that came to the University of Utah, had been on a trampoline, had a fall, had right arm paresthesias and some weakness, was basically intact with the exception of her right C7, which was weak and numb. Otherwise healthy, 27 years old. These were presenting films. She's got this C1 burst fracture. She's kind of lost her articular pillar. She's got a C6-7 facet fracture with a little bit of anterior translation of that SAP and some foraminal stenosis that kind of explaining her weakness. So she comes in with these injuries, and so I start to think, how do I want to think about this? And so for this, I think the primary is a little bit unclear. So her symptoms are really coming from her C6-7 injury. I think radiographically, her C1 injury is more concerning for stability. So I start to think about how do I want to address each of these fractures. For C1-2, do I want to do a fusion? Do I want to do an osteosynthesis? Do I want to do a halo? For 6-7, I can go anterior, I can go posterior, I can treat it in a brace. And as I start thinking about this for this person, I think, well, she's young. I'm really worried about her radic, her stenosis at 6-7, and then late deformity at C1-2. So I can achieve kind of both of those goals by doing kind of a small surgery in ACDF at 6-7, and then a halo to prevent that late deformity at C1-2. And so this is her immediately post-op, and then at 6 months, and she did well. And so again, I think just taking each part and then putting together a plan that's logical and kind of systematic. So when you have a spine fracture, it's important to look for others. So things move really fast in the more complex traumas, and I think we tend to jump to conclusions. So double check your verts, double check your screw paths, double check your imaging, look for AO injuries, determine your primary injury, and really prioritize that in your surgical plan. But you don't have to sacrifice your secondary injury in your plan. And then just remember that the instability is not always greater than the sum of its parts. And so just because there's a fracture in an adjacent level doesn't mean that you have to continue to include those levels. All right, thank you.